this is Gail Hausman from the ALS Association Greater Philadelphia chapter, and I'm here with Janie Eskovitz, who is one of our social workers from the ALS Association, and we're going to be talking about Alfonso Morris, who is a fictitious patient. A lot of times the social worker and I will go in to meet the patient together. Sometimes not, but usually we do. Mr. Morris, this is his first time at our clinic. So the very first thing that I would ask him is, what does he want to be called? It's just kind of a common courtesy to say, do you want to be called by your last name or your first name? So assuming he says he wants to be called by Alfonso, that's what I would call him. I would then introduce myself and my role at clinic, which is primarily mental health, and then also talk about my role with the chapter, which is a little different at times. I would probably ask him how he's coping since he got the diagnosis, get his input, and also ask him about like if there's anything that seems to be helping him, because he's obviously having a hard time with the diagnosis, as noted on a later screen. And I would also say, is there anything that he's doing that's not been helpful? Like perhaps maybe isolating hasn't been a helpful tool for him. And I would talk to him to see if there's any kind of possible things that he can do that might help with the coping. Like I'm thinking maybe perhaps like a visit from his spiritual, his minister, or perhaps limiting friends that visit, because sometimes people want to visit and people with ALS are not open to everybody. And then I would also ask the same questions of whoever came in with the visit, and that would probably be Mrs. Morris, see how she's doing, and also their 20-year-old college students. I would ask them if they had any questions about ALS, and I would answer them. I would try to work in that it sounds like Mr. Morris is experiencing some grief, which is completely normal. I think the message being pretty much everybody with ALS experiences some grief, and that it just needs to be there. And then might bring up what might be helpful for his family. For instance, with the college students, perhaps if they have questions, they can reach out to me. They may be having trouble struggling with the fact that their dad has this illness. There's probably some sort of therapist or counselors that they can speak to at school about this. Sometimes families find it helpful to get involved in our events with the chapter. There might be perhaps for Mrs. Morris and Mr. Morris, they might be interested in attending one of our resource groups, which is a support group for people and their loved ones with ALS. And then I would leave them my contact information and encourage them to reach out to me if they have any questions or anything that they would like to discuss. So Janie, you want to take
Yeah, sure. So because I usually am the first contact with the families, I was able to talk with Mr. and Mrs. Morris prior to coming to clinic. They are registered with our ALS chapter. They have signed a consent. And one of the concerns that Mr. Morris expressed to me was that he's currently a physical ed teacher. He's out on short-term disability, and he's just not quite sure what happens next in terms of his insurance. So I would talk to Mr. and Mrs. Morris. I'd like to have somebody else in the room with the patient, because sometimes all this information can be overwhelming, and it's helpful to have another ear to listen. I would ask Mr. Morris to perhaps talk with the HR folks, perhaps the teachers union, to find out if he has long-term disability. His wife is also a teacher, so she may be able to help advocate and assist her husband in finding that out. If Mr. Morris decides to leave his role as a teacher and go out on disability, we want to find out if the teachers union or his employer offers him health coverage after he leaves work, and if they do, at what cost, and is he eligible for COBRA, or is he eligible to go on his wife's insurance? Has Mr. Morris also been educated about Medicare? We know that folks that are under the age of 65 and have worked a certain amount of work units may qualify for Medicare and Social Security disability. So I might give the family some information, some contact information, and a little homework that they can begin to explore what the coverage is and how they want to work this out moving forward. He does live in a 4-story home, so there may be a need at some point for the family to look at perhaps a ramp or stair glide, and that might be something that would be shared with the other disciplines down the road, and whether or not we would utilize the ALS Association programs for that. Gail did talk a little bit that this Mr. Morris is active with his church and his men's group there. So if he is experiencing any type of isolation, perhaps there are people at the church that could provide some support to him, as well as to his wife, as well as to the children. You know, the children, we're not sure, are they in college? Are they working at home? How are they coping? If they're in college, there are resources for counseling there, helping the children to find out resources if they want to find out how they can get connected and learn more about the dad's disease. And I would encourage maybe Mrs. Morris to maybe perhaps join my online caregiver lunchtime support group, where perhaps she might want to meet with other people going through a similar journey. I would take it from there. Like Gail, I would leave them my name and number, and I would most likely connect with them several times just to make sure they're doing okay, they understood what information we provided, and to provide them with guidance again. That's it.
Done, Joan.
Hello. In this session, we'll discuss the role of the neurologist and the ALS team, Judy Guarnieri and Chris, in when we first meet the patient. In this case, we are meeting a new patient that has started his journey with difficulty in the hands and arms, and unfortunately progressed gradually to have some bulbar weakness. In meeting first patients with ALS, we are concerned, first of all, is this the right diagnosis? And this is a major portion of the workup that we do. We have to consider, you know, the tempo of the disease. Does it fit what we know and have experience with in ALS? What are the first symptoms? And sometimes it's really hard for patients to go back and remember what was their first symptom. But in the case of Mr. Alfonso, we may ask if he remembers difficulty manipulating keys, dropping objects, or whatever the first thing that caught his attention was. The other thing we want to know are common things like, has there been a change in the muscle bulk, if there has been muscle twitching, stiffness. And when we ask these questions, they guide us to determine the following. ALS is a disease, as you can see on my slide, in which there is, number one, progression, unfortunately, and number two, the typical ALS involves both upper and lower motor neurons, and those category of neurons are responsible for when they're sick, they can present in the patient in a different manner. So when the upper motor neurons are involved, we know that because the reflexes are very brisk, that's what we call hyperreflexia. People complain, unfortunately, of stiffness, of difficulty feeling their arms or legs as quote unquote boards. They can easily cry or laugh. This is called pseudobulbar affect. And the other reflexes that we look for are Babinski or Hoffman's signs. Those are signs that we only have as very young people when we are babies, and over time they get suppressed by the upper well-functioning nervous system. But when people develop the disease, unfortunately, they get released and we can see them again present in patients. So these are some of the things that we will question our patients. And then the lower motor neuron signs are the signs of atrophy, meaning the bulk of the muscle is less, muscle shrink. Their patients do tell us about their weakness, and fasciculations. Fasciculations means muscle twitching, twitches of muscle that we do not intend to twitch, but they do occur. And the opposite of what we talked about, upper motor neuron, in lower motor neuron predominant involvement, people lose their reflexes. And the big difficulty with ALS is it's not a one case scenario. Unfortunately, the disease can start in very different body areas. And the case that we're discussing, it started in the hands and then moved on to involve a little bit the swallowing function and not so much the legs. So this is just a picture to show that, you know, different areas can be involved, the swallowing, and a different combination of predominant upper, predominant lower motor neuron involvement can happen. And it's not only that, the presentation is different, but unfortunately, the other big difference is in the progression of disease. Some people take longer, some people unfortunately have a very speedy and fast course. So with all that being said, I'll pass on the word to Judy so she can add on to additional comments.
Yeah. Okay, so as Dr. Ilieva talked about being more sure of, you know, that the diagnosis is proper, with this particular patient, even in addition to the signs of ALS is upper and lower motor neuron signs, the other real concern is that this patient has some, it sounds like she has some problems with, he has some problems maybe with depression. He's very sad. He's described as sad, making poor eye contact. And this can be a real, you know, a situation that may need to be addressed, you know, on that first visit a little bit. And luckily we do have the entire team. You know, we have Gail as a mental health nurse, Dr. Ilieva as a neurologist. We have a palliative care specialist, and really a lot of the responsibility for monitoring some of these symptoms and assessing them comes to the entire team. You know, different people have different relationships with the patient and can pick up different things. You know, so in addition to being sure of a diagnosis, we're also looking for any warning signs that could become, you know, a problem or things that we need to be watching for. You know, this particular patient seems to be having the weakness in his arms, some beginning signs of weakness in his legs, some bulbar signs, and also his respiratory status seems stable, although the measurement of his cough is a little bit weak. So those are all things that can contribute to problems with swallowing and things that we need to, you know, pay attention to. So there's a lot, you know, they can be pretty complicated, and, you know, so you kind of rely on each other a lot, you know, for help.
And to add to Judy, we also ask, this is Chris's role and he can explain it as well, we do collect information about other diseases. So Chris is very helpful in helping us understand what other conditions the patient may have.
Mhm. Yes, I usually collect all the records and everything before that first visit. And during the multidisciplinary clinic visit, the first visit with the entire team, I also make sure that they meet everyone, since even if they don't necessarily need every single specialty, they should still establish a relationship with each specialty.
Right.
I also wanted to note that we also we have them meet research usually in that first visit, just to kind of get them on the ball with that too.
Right.
And finally, although this is an ALS specialty or an ALS clinic, as Chris was saying, we need to know about previous conditions that may impact it. For example, asthma or smoking can have its influence on the disease. The other thing that I thought was interesting about the patient was that he was fairly athletic man, and that's also a trait that unfortunately goes together with some of the ALS patients. On the first slide that we showed, and it's quite well known that Louis Gehrig, a very athletic man, also developed the disease. So we don't necessarily know how athleticism is linked to ALS. Some people believe that there might be a susceptibility of those patients. And some other people think that maybe exposure to pesticides, for example, on the fields, on the grass for soccer or other environmental factors also influence the disease. But we do take into account the job and the exposures, if we can have those. For example, any traumas, head traumas, they're not causative of the disease, but we do know that they can speed and accelerate the disease.
So this presentation is a presentation that we see fairly regularly in the clinic, and it's one that shows somebody who is fairly medically stable, but is beginning to experience some functional impairment, as well as secondary effects of ALS. And I say early just because he's having just some difficulty with cramping, and then also with doing dexterous or fine motor movements. And those are things that we often see earlier on in the disease, and unfortunately sometimes those deficits become even more pronounced. The cramping that we see a lot of times often is involved or provoked the more someone tries to use muscles, especially those muscles that are involved or that are weak, as is the case here when he's using what we call the intrinsic muscles of the hands. They're muscles that normally aren't as strong as muscles in our arms or our legs, and are actually prone to fatigue, but doing repetitive motion, doing motion that requires activation of them can produce symptoms. And a lot of times these are the symptoms that they have. They'll have cramping while they're using them. They'll have excessive soreness after that. The other thing that this patient is experiencing is one that we hear about a lot, is what is pain, usually in areas where there's already a lot of stress. So typically where we see this is in the shoulder girdle, and then also in the hip girdle. And it's most likely biomechanical in nature. What we as a group really try to figure out through talking with the patient and then through our evaluation of them is exactly that. What about their history might indicate that this could be maybe an underlying issue, such as a chronic painful condition? Could this be arthritic in nature, or is this more biomechanical and potentially maybe an overuse sort of presentation that we often see when there's weakness of the postural and or stabilizing muscles. One of the things that I really like to partner with patients to do is, if we do identify this, there's lots of things that we can to do to try to make it more manageable and potentially to prevent it from getting any worse. A lot of times that involves postural correction, some courses of therapy to look at doing range of motion and trying to do things in a way that protects function and prevents further injury. And then unfortunately, if those efforts aren't successful, what we can recommend is bracing to try to take some of the biomechanical strain off of those muscles. And then even still, if there's not a response to that, there's interventional things that can be done. And for many of our patients, those are very rewarding when an intervention is introduced that can provide pain relief, where a lot of our other efforts or potentially some of the pharmacological agents that are out there may not be as effective for treating this as an intervention is.
And I'm sorry, there we go. And I'm going to start with Dan again, please.
Okay, so Mr. Morris is a 58-year-old male with a recent diagnosis of ALS. His pulmonary function seems to be pretty high, pretty close to almost normal. This would have me presume that he's mostly limb onset, but with some bulbar involvement. As you can see, that he's had a little bit of slurred speech, some issues with his saliva. This is where we would employ, some of the least invasive measures for addressing the salivation. Another thing is that he's having some early swallowing problems or eating problems, says that he's occasionally choking. So usually in this instance, what we do is, well, my approach is really to try to keep the quality of life high for somebody who's having early trouble swallowing. What that means is basically not to modify too much, but maybe modifying the behavior more than the actual consistency or type of food that somebody's eating. So what would happen is this person would come to the clinic. We would be able to demonstrate what the problem is, and then talk through different types of compensatory strategies in order to minimize or even eliminate these issues that the person's having. That 9 times out of 10 usually works, and in very few cases at this stage do we need to do any big change of the consistency of the diet.
Right, and I would just at this point, it's early on, so a couple of things right off the bat that I tell them is definitely weigh weekly. Start, increasing those calories if you can, and I know that somewhere it said he was a former runner, so I look at that and I look at how they were eating in the past, and to me, I mean, if he is a former runner, if he's running for, health purposes, he may be a very healthy eater, which, is good and bad in that if he has, all of his life eaten a certain way, a lot of fruits and vegetables, very healthy, maybe not a lot of fats or not a lot of calories, we're gonna have to change that a little bit. So, I do usually recommend adding those extra fats, because fat has double the calories of carbohydrate and protein. So it's easier to get those extra calories in through fat calories, extra gravies, oils, dressings, that kind of thing. And the fact that he's starting to have a little bit of choking, maybe changing that consistency of food ever so slightly by making things a little softer, adding a little bit more gravies and sauces and that kind of thing. He was also, I think it said, having issues with his arms, feeding himself. So if the food must be cut by someone else, just to make sure that the family members, realize that that's a big deal. A lot of times I think, maybe people tend to forget that, okay, here's your food, but they may forget that, oh yeah, he does need help cutting. And a lot of patients are reluctant to ask for help. So making sure that food is cut up even before it gets into the mouth. A lot of times I will recommend that even as a calorie preservation, because people don't realize how much energy it actually takes to chew and chew a lot of, food, such as, a tough steak or a hamburger or anything like that. It takes a lot of energy to manipulate that food in your mouth. So it doesn't hurt to kind of have that food, a little bit smaller before it even goes into the mouth. So I would talk to them about all of that.
And so it's documented here that he can feed himself slowly. One can only assume he might have trouble with cups too. So what would your tips be for him to stay hydrated if he can't do this?
If he can use a straw, we have those, we have long straws that he can kind of just, use the straw if he still has that sucking ability. A lot of times cups with lids can help, with spilling and that kind of thing. And again, making sure someone's there to help. There's also, to make sure that he can get his fluids in, there's also foods that are, considered made up of fluid, like puddings, Jello, ice cream, tea, soups. You can count the fluid in those things as to get some hydration into the patient.
From an assistive technology standpoint, as was already discussed, some arm weakness. So with detectable speech disturbance, talking about perhaps using an augmentative communication device to supplement natural speech. So a lot of people, when I talk about, there's devices out there that will speak for you, what they hear me say is that, oh, you want me to stop speaking verbally. And that's not the case at all. We just want to be able to supplement speech so that, as we discussed with the prior case study, we can alleviate some of the communication breakdown and alleviate the person that's speaking not being as angry or as upset with people for not understanding them. So introducing that, saying use it when at night if your voice is worse, or set a time limit with your family. I'm going to repeat something twice. If you don't catch it by the third time, I'm going to grab my iPad, my communication device, my pen and paper, so that you have the ability to communicate and not get angry and not upset other people, because they value what you're saying. They really want to understand you. They're trying. It's simply that sometimes words or sounds, particularly, sometimes, and Dan can attest to this, just getting the tongue to the roof of the mouth, right, to say certain sounds is really difficult. So that's what I would be intervening with at this time. Also, maybe talking about, other access methods for like the television. I would be looking at, okay, can he use a smart speaker? And a lot of times a smart speaker like an Amazon Echo or Google Hub or Home, people perceive that, oh, I can only use that if I can verbally speak. That's not true. Those smart speakers will understand whatever command is coming out, whether or not that's through a speech generating device or through an iPad or an iPhone. As long as you give the trigger word, which in the Amazon products is Alexa, that smart speaker will do whatever you want it to do. So that can be really helpful, especially with people who have arm weakness, because they say to me all the time, I just want to turn the television channel. Well, I can make that happen. I can give you recommendations, and you can still enjoy your television or your Netflix or whatever. So that's what I would be talking about here. And just to make sure we haven't forgotten anything. I don't think so. So, but we would be bringing in the team also to talk about, you know, the physical and occupational therapist might be working with Carol, right, on access, like food access issues, or maybe a feeding arm if they're, you know. So again, we work as a team to problem solve.
Right, adaptive equipment, they
Yes.
bring, you know, bring in a lot just to help.
Yep. So that's our case studies. And if you have any questions, I would advise you to get a hold of your nurse practitioner. And if you have a question for Dan or for Carol or for me, they all have our emails, and they can get in touch with you for you to us. Right? And I want to thank Dan, Carol, thank you for your participation at the Help and Hope Symposium.
Absolutely, thank you.
Thank you.
When visiting with Mr. Morris, I would assess his major symptoms, such as his pain, the difficulty with salivation, his mobility issues, and his mood disturbance. I would be concerned that he is exhibiting signs of depression, or quite possibly that he's displaying grief. I would assess the impact of his symptoms on his mood and allow him the time to express his concerns and emotions. This is perhaps the most important part of my intervention. I would assist him with strategies to address the issues impacting his quality of life from his perspective. I could review potential interventions to improve his quality of life and discuss with the team regarding the high impact interventions to help him improve quality of life from his perspective, such as his mobility, his depression, his pain, or his excessive salivation. An evaluation for safe mobility and devices to improve mobility and connections to community would probably be the foremost interventions to be considered. And I would help him access support for his home modifications. There could be potential for mental health referring for counseling if need be as well. Okay, that's the end.
And so Laura and I are gonna go into the room to introduce ourselves and to meet Alphonse and his family and the people that are with him for this first visit. So normally, my role in the clinic is a dual role, right? And it is even more important when I meet new patients that first I go in as a center director, and I really want to get a sense of how the first clinic went. What is the impression, the feeling between the impression of the patient, their families? We become a family eventually. And because of the complexity of ALS, because of the challenges that an ALS patient and their families really face, the idea to create this center as a clinical research integrated program and with a concierge approach, for a lack of a better term, was really also to serve the purpose, to really cater to the needs of every patient. So after introducing myself and Laura, I really asked this question, and I really want to have a conversation with the patient about that. Why? Because we always want to improve, we always want to be better, and we always want to create a sense of community from the get-go with our patients, because again, this is really the motto and the mission of our center, which is really to empower life, therefore to help patients through a symptomatic treatment, personalized symptomatic treatment, to empower life and improve their quality of life, to enable research in the context of a clinical research integrated program, and obviously to envision and to research for a cure. The second step, then after having this conversation, which normally is a very informal conversation with the patient, and establishing really a relationship and a friendship, then I wear my second hat, which is the researcher hat. And contrary with what Laura does, that she will explain in a second, I give an overview of really the complexity of ALS and therefore the needs of research and the need to involve the patient early on, even in the basic of what we call translational research. Why it is very important? Because we strongly believe that an educated patient, for a lack of a better term, is a happy patient. And we strongly believe that oftentimes the research is so remote from the community and from the patient that oftentimes it may sound paternalistic. We don't have the disease, the patients have the disease, and it is really our job to explain why we still don't have an effective treatment. Not for the lack of trying, but for the challenges that the disease imposes on us every day. And so I normally go in and I really ask if they have any questions for me. And the questions vary. Alphonse can have a set of questions because before coming to clinic, he and his family have really researched the in and out of ALS. Some other patients really are not yet ready to dig into this research. And so the question may vary. And if those questions are not there, that's perfectly fine. I just give an overview of the state of the art of ALS research and our understanding at this point, not only in the center in our 4 laboratories, but in the ALS community in general, of the state of the art of ALS. And obviously then Laura digs in more into our clinical research program.
Yes, thanks, Piera. So as Piera was just mentioning, our first visits with a patient can really vary. And really, we just try and keep a very informal first meeting. A new patient will be meeting a whole host of new team members on their first visit, so it can be quite overwhelming. So really, our take-home message would be that we have a presence in the clinic. We are here always for patients to answer any research questions they have, and that there are research opportunities for patients to be involved in, whether that be more observational clinical trials. So we have a biobank program at Jefferson, but also that there are drug clinical trials, and we can help patients get enrolled in those if they have that interest. But really, this first meeting is kind of just to gauge a patient's interest level and let them know that we are there to support them however they might want us to.